Assalamu alaikum, sabah al-khair. Good morning everybody, my name is Ibrahim Sbeih. We are transmitting live here from Amman, Jordan, and the backdrop is a slide of Petra of Jordan. That's a photo taken 100 years ago, and this is Petra of Jordan today. We are transmitting from medical campus of Farah Hospital in Amman, Jordan. The item for today is pineal locus tumors, and some people may ask why locus. It means pineal location, and I'll explain why. We'll put clinical, radiological, operative, and pathological correlation. Pineal gland. This is a photo of pineal gland. It has a stalk. That's the pineal gland. Why it's called pineal? Because it's like a pine at the back of the branch stem. This is superior colliculus, one side, on the other side inferior colliculus. This is midbrain. So it is on the back of the midbrain. And because it looks like a pine, it's called pineal. Some people call it pineal, related to the penis. It's not. It's awkward terminology. You should say pineal because it is a pine. بالعربية الغدة الصنوبرية because it is صنوبرية. So it is pineal, not pineal. Pine. So this is the pineal gland, the back of the midbrain. The pineal gland is an endocrine gland, like the thyroid, like the pituitary. Pituitary الغدة النخامية. Pineal is الغدة الصنوبرية. Endocrine gland that secretes melatonin, which regulates your sleep. It has very much to do with our sleep pattern. So in the evening, the pineal gland takes some information that it is night time, so it starts secreting melatonin so that you will feel sleepy. God created this, that we sleep at night and we wake up in the morning. So when it comes to the evening, melatonin is secreted so that we could sleep. As we are sleeping, the light comes to our eyes through our eyelids. The pineal gland senses that, and then it decreases secretion, meaning that it's enough sleep and get up. So if you fly in the airplane, you get so-called jet lag. And for nurses and residents who do night shifts, because you keep seeing the light during the night, so your eyes sees the light, there is no melatonin, so you keep awake. But then the following morning, you are completely collapsed. Also, people who travel a lot like myself, we get the jet lag. It's because the lights in the airplane are on, so you don't sense light, you don't sense night and day, and you just cannot sleep. Some people are prescribed melatonin tablets if you are traveling.
Doctor, as a matter of fact, for melatonin tablets, recent study shows that they are useless.
They are absolutely useless, yes.
Yeah, the treatment, the absolute treatment is bright light therapy.
Sure.
You give the patient in front of bright light and they can face bright light.
That's if he has a jet lag.
Yeah,
but
that's why
pharmaceutical companies are making hell of money selling the melatonin.
As a matter of fact, you find jet lag more if you travel to Britain,
I
not to
agree.
India.
I agree. I'm just mentioning it from the physiological point of view, that during daylight, your eye sense the light. During nighttime, no light. You go to the supraoptic nuclei of the hypothalamus that will relay this to the pineal. Also, the pineal will take it from the sympathetic plexus, and that's how the melatonin works. So it depends on the clock, our clock, biological clock, at 6 a.m. or 6 p.m. 6 a.m. highest blood pressure. Here is the lowest blood pressure. Here melatonin starts to be secreted, telling you go to sleep. Here melatonin is stopped, making enough melatonin get up. This is the biological clock that God created. وَجَعَلْنَا النَّهَارَ مَعَاشًا وَجَعَلْنَا اللَّيْلَ سُبَاتًا, for you to sleep at night. So this is the pineal here, seated, deeply seated. If we take a close look, this is the hypothalamus. This is the line separating the hypothalamus from the thalamus. So the hypothalamus is just like that, like the head of a bird. And here is the midbrain, tectal plate and tegmentum of the midbrain. And this is the corpus callosum. Underneath this brain of the corpus callosum is the pineal gland, tucked in a very deep place. Again, corpus callosum, roof of the third ventricle, pineal gland. This is the tectal plate, superior colliculus, inferior colliculus. This is the pinnular commissure, and then the pineal. Anterior commissure, of course, is there. Again, the inferior sagittal sinus, joined with the internal cerebral veins, joined with the vein of Rosenthal to make the vein of Galen. And where is the pineal? It's there, in the middle of those veins. Corpus callosum, splenium, midbrain, appendular commissure, and the pineal. Internal cerebral vein, the epicentral or mid-cerebellar vein, and this is the pineal, and this is vein of Galen. Again, if you look at it from above, this is cut section of the midbrain, crus cerebri, substantia nigra, aqueduct of Servius, and then this is the hiatus through which the brainstem passes, and this is the vein of Galen, the straight sinus. The pineal is underneath there. Very, very difficult area. And this can be seen in this angiogram, MRV. You can see the straight sinus. This is the internal cerebral vein. This is the inferior sagittal sinus. And where is the pineal? It is here. And you have to understand the relationship with the tent itself, the folks and the tent. This is a common question in the board exam. I would ask the candidate, what is 11, for example, and they should know, because this is a basic knowledge of neurosurgery. Unfortunately, lots of neurosurgeons do not know this, let alone the neurosurgical residents, as if it's not important. It is of great importance that one should know all these sinuses. This is a beautiful view from Yazarjil. Muhammad Razi Yazarjil is the most famous man neurosurgeon on earth. He's called the man of century of neurosurgery, and this is in his book. This is a very valuable book, and it is there for people to read. And they go and read from a small, tiny book called Greenberg, which is, to me, is useless. Because this teaches you exactly what it is. This is internal cerebral vein one side, internal cerebral vein of the other side. Coming from where? From septal vein and thalamostriate vein. They meet together here. They are joined by vein of Rosenthal. They form the vein of Galen and then the straight sinus. And these are the cerebellar veins. And where is the pineal? Tucked here, in the middle of those veins. One should know the exact anatomy. Venous system is ignored system in all the bodies, in every body, in every discipline. Veins are as important as the arteries. And the frightening thing is the anatomical variation of joining the internal cerebral vein with the straight sinus. Very much variable kind of anatomy, and one should be aware of this if one wants to go and operate in that area. That's the picture you see. This is the tent, and this is vein of Galen, internal cerebral vein, vein of Rosenthal. The pineal is here. So this is the tent, and these are the veins, and this is the pineal, and these are the branches of the superior cerebellar artery. This is the posterior cerebellar artery. Very unique anatomy, which is not good for the people who don't understand that. Yet they mismanage these cases. So here you are, to reach the pineal. That's the anatomy you should know. Frightening anatomy. This is the tent have been removed, and you are looking at the veins coming from the third ventricle to the vein of Galen, and the pineal is hidden there. So we know now what is pineal gland. It is endocrine gland tucked at the back of the brainstem. Does it have tumors? Yes. Some tumors arising from the gland itself, others arising from the structures around it, or it can be a metastasis. That's why we say pineal locus, not pineal. because we don't know, we cannot differentiate that this tumor is arising from the pineal itself or from the surrounding structure. That's why we say pineal locus or pineal location. It's a tumor of children. 3 to 10% of tumors in children are pineal tumors. Very low percentage in adults. That's why a pediatrician and the GP should be fully aware of that. One of the famous people in the surgery of pineal is Alexander Konopalov, who's a close friend of mine from Russia, from Bordinko Institute. And he put his experience in these years, about 25 years, and he had 287 patients. Bordinko Institute, they operate on something like 5,000 cases a year. So this number is small for this kind of lesion. I asked Dr. Maysa Al-Husseini to be here, and she couldn't, but I'm proud of her that back in the year 2009, she published in the Journal of Neuro-Oncology a paper, not her work, but she went into the SEER data taken from 17 registries in USA. They looked how many cases they had, and they had 633 patients. So she looked at these tumors and she defined which what kind of pathology there is. Maysa Al-Husseini في King Hussein Cancer Center. So we said pineal tumors are commoner in children. Unlucky for us all that 3/4 are malignant tumors. So most of the time we are dealing with malignant tumors. What are these tumors? Either they are germ cells, which is the majority, or from the pineal parenchymal tumors, or glial tumors or miscellaneous. So the commonest is the germ cell tumors. So this is germ cell tumors. This is called the primary parenchymal tumors, and then the others. Germinoma, which is the commonest, are divided into two sides: true germinoma and the non-germinoma. Constitute 60-70% germ cells, germinoma or the non-germinoma. The non-germinoma are these: teratoma with its types, mature, immature, yolk sac tumor, epithelial carcinoma, choriocarcinoma. 60% are germ cells. And this is example of germ cell tumor. The thing about germinomas, they are good. They respond well to chemo and radiotherapy. You don't even need to operate. If you can diagnose them, you don't need to operate. So these are examples of germinomas, various examples of the germinomas. And they have markers. The alpha-fetoprotein and beta-gonadotropins, they are positive in germ cells, both in the blood and in CSF. The non-germinoma, like these. Now when you see this, you don't know, is this a germinoma or non-germinoma or meningioma? So you do various tests to make at least something to point to you where you are. Various examples of non-germinoma, teratoma with its types, the mature, the immature, and so on. Mature cystic teratoma, so they can be of a huge size. Again, looking at these, you cannot tell what type of histology you are dealing with. Immature teratoma, embryonal carcinoma, choriocarcinoma. I'm just putting these because these are real cases. This is not imaginary. This is not just you read in the book. They are there. Cases that you will face. This is a teratoma. And there are rare types of pathology. Dr. Abu Farsakh would appreciate this kind of primary parenchymal. So this is recently is mentioned in the WHO classification. It should be written in capital here. So this is one of the cases in the journals about this pineal annulage tumor. Please come in. Sometimes you have mixed germ cells, germinoma and non-germinoma. The second group is the pineal glandular tissue from the gland itself. So that's why we call them pineal tumors, pineocytoma, pineoblastoma, something intermediate. So pineocytoma, pineoblastoma, and intermediate, they constitute 30%. Pineocytoma is considered grade 1, pineoblastoma is a grade 4, high grade. So this is good, this is bad. This is examples of pineocytoma. So they are less aggressive than the others. It comes in young adults, while the others come more in children. Example of pineocytoma. Now you look at this pineocytoma, and for the radiologist, he will fall into a problem. All the radiologists here, they will agree with me. Is this a pineal cyst, or this is a pineocytoma? Is this pathological, or this is good? Do we need to operate and give chemoradiotherapy? It's very important for the family that you should tell them what's the answer. I will come back to that. So pineocytoma, different examples. By the way, these are all my cases. I'm not putting to you any picture. And when I put, I will tell you, this is taken from whatever. The intermediate type is aggressive type. It's malignant. That's examples of the intermediate type. Again, when you look at this, what is this? Germinoma or pineocytoma or what? So by experience, you know, you come to know. And by doing your investigations, intermediate type. Pineoblastoma is the most malignant. Unfortunately, it comes in children. It's bad histology, very destructive, very infiltrative. And infiltrative for what? For midbrain. So this is pineoblastoma. And always, in the big percentage of cases, they come with hydrocephalus. And again, what is the treatment of this hydrocephalus? In Jordan and in the Arab countries and the Middle East countries and the third world countries is a shunt. And this is a crime. I call it a disease. The shunt is a disease of the third world countries. Pineoblastoma. And then we use the alpha-fetoprotein and the HCG to differentiate. So when it is positive and when it is negative, and the others. In fact, these two are recently being used. Melatonin is the least useful, but these two are the most useful. So by doing this, you may know whether this is a germinoma that does not need surgery, or whether it is non-germinoma that needs surgery. So they are used for diagnosis and they are used for follow-up of treatment. Third group is the tumor of the supportive and adjacent structures. It is not from the pineal itself, from the surrounding structures. Astrocytomas, gliomas, epidermomas, choroid plexus, papilloma, meningioma, you name it. Surrounding structures, not from the pineal. That's why we cannot differentiate. That's why we say pineal locus, pineal location tumor. We don't know that it's coming from the pineal itself or from surrounding structures. So this is astrocytoma. And this is one of my patients with this. Turned out to be a pilocytic astrocytoma, grade 1. This is the histology of the farsa, so it is confirmed. This is astrocytoma, and not a pineoblastoma. Again, different types, oligodendroglioma. Oligodendroglioma there, yes. And what's happening here? It's a disease. Disease which we are transmitting to our new generations. We don't tell them the truth. We are still practicing the medicine practiced in 1960s to put a shunt and send for radiotherapy. It's a crime that should be stopped. Glioblastoma, high grade, ependymoma, and also a type that is related to ependymoma is the papillary tumors. Again, the one who would appreciate this is Dr. Farsa here. Do we have any histopathologist other than Dr. Farsa? No. Meningioma. Why should meningioma comes there? Because we are at the falcotentorial junction, so meningioma is common. Again, this is one of my patients. As I said, we said papillary tumors, and we have various meningiomas. Epidermoid. Why should epidermoid comes there? Unique type of epidermoid, they come in the pineal region. I have almost 9 cases of epidermoid in the pineal area. Now, regardless whether it is pineal tumor or it is epidermoid or arachnoid cyst, you have to know the anatomy. If you don't go there. This is one of the epidermoids I treated. Again, 36-year-old female patient with this. Different types and kinds of epidermoids. Dermoid, difference between dermoid and epidermoid. Dermoid contains all the skin structures. Epidermoid only contains the epidermis. And sometimes they have lymphoma in that area. Lymphoma in the pineal gland, yes, lymphoma is a disease that should be respected. It is one of the common lesions that come to the brain. You don't need to be immunocompromised. You don't need to have HIV positive to have lymphoma. It can be a non-immunocompromised. So this is a case of lymphoma. And here's the lymphoma man coming in.
Just as I walked in.
Exactly the right time. And this is a lymphoma. So whenever he hears lymphoma, you see his smile from ear to ear. I call him lymphomaniac because he loves the lymphoma. We have the non-neoplastic, non-tumor, like arachnoid, cysts, cysticercosis, vascular lesions. They are not tumor, arachnoid cyst. And then the pineal cyst, the question of pineal cyst. What is this? A pineal cyst that you should dismiss until the family people come to me, a mother and father and a child, they are petrified. We have a tumor, and we were told that we need surgery or radiotherapy. And then they come out happy because you tell them, no, this is a pineal cyst, we're going to watch, doesn't need surgery. So you need to have the knowledge about this pineal cyst. And I come to that later. Pineal cavernoma coming in that area. We have seen cavernomas coming in the optic chiasm, so it can come anywhere. And this is one of the major problems in pediatric surgery. Sheikh Dr. Saad Hamdan, as a pediatric surgeon, this is a very difficult problem of vein of Galen malformation. And this is vein of Galen being going venous, the drainage to the superior sagittal sinus. Of course, we have metastases that come from anywhere, and this is metastasis from bladder, I believe, from bladder carcinoma. So, in addition to seeing an MRI with a pineal lesion, in addition to these lesions, could it be something else? Yes. Hypertensive bleed that comes in the midbrain, and you may mistake this for a tumor. Midbrain infarct, that you're mistaking it for pineal tumor. Vasculitis in that area, yes, of course. We are practicing medicine with so meager little information. You have to believe this. I don't know how we are practicing medicine with very little information. These are cases that are there, whether the vasculitis is due to Behçet disease or lupus erythematosus. Wernicke encephalopathy and osmotic demyelinating syndrome. Dr. Shaheen, you see this in pediatric age group where we have osmotic demyelination, and this causes these changes in the midbrain. And you said, oh, this looks like a pine, so this is not a pine myeloma. So what is the clinical presentation, please? Sure.
Just,
give me a break.
Morning. Can I just give an oncological insight in what the implications of a pineal lesion management-wise from this differential diagnosis? To start with the possibility of metastases, I cannot stress enough the importance of the ABC in medicine with good physical and history taking. And you really don't want to embark on a long differential diagnosis story when you have failed to examine the breast of a patient and you're missing breast metastases. I can't tell you how many times we've been consulted for a brain lesion that nobody bothered to examine the breast, and there was a clear breast lesion, and that was all the metastases. And the other thing applies to lung, prostate, etc. Now, the importance of hammering the word lymphoma, as rare as it is, in the CNS track repeatedly is because lymphoma in the CNS, primary CNS lymphoma, does not need a complete excision. It needs chemotherapy with high-dose methotrexate given at every 2-week interval, and the treatment is radically different from any other brain lesion or brain tumor that you may see. And this is one side to see primary CNS lymphoma, not to mention extension from lymphoma elsewhere. Other lesions that would have implications in the management, meningiomas, as we continue to hammer, they need proper surgery, radical excision from the get-go whenever possible, because if they don't, then they're doomed to a course of a recurrence that would ultimately lead to their demise. Ependymoma, after a proper surgery and radical excision, some of them will benefit from cisplatin based chemotherapeutic regimen and after radiotherapy. Glioblastoma multiforme, this is an incurable malignancy no matter what you do, and after proper surgery they will need radiotherapy and adjuvant chemotherapy. The same would apply for high-grade gliomas as well. So these are the pineoblastomas are just horrible tumors, and they need to be treated radically with surgery. Chemotherapy can be used, but really the outcome is horrible. Pineocytomas, there's really no role for chemotherapy in them. Mixed germ cell tumors, I cannot stress enough how important it is not to forget that you can have primary CNS germ cell tumors in the CNS, as well as metastases from systemic germ cell tumors. The presence of CNS involvement in germ cell tumors does not preclude giving them treatment with curative intent. They're still treated with curative intent. Primary CNS germ cell tumors are treated with curative intent. After surgery, the new approach is actually to give them adjuvant chemotherapy in an attempt to either delay radiotherapy or to minimize the field because of the long-term toxicity they can get with radiotherapy. A common mistake is to give them radical course of radiotherapy after surgery, postponing chemotherapy. These patients will have horrendous long-term CNS-related toxicities. You can cure them of their disease, and then they're doomed to that course. Same will apply to choriocarcinoma. The CNS involvement of systemic choriocarcinoma is still treated with curative intent. And this is a good place to talk about this in Farah Hospital. Choriocarcinoma with CNS involvement are treated with curative intent. A forgotten usual thing. Now, CNS involvement of germ cell tumors, either primary or secondary, in the pineal region is quite common. And you have always to bear this in mind when you're looking. You can have normal systemic markers, you can have normal CSF markers, and still this would be the disease. After radical excision whenever possible, after proper surgery whenever possible, what you will need is systemic chemotherapy with curative intent, possibly to be followed by reduced field radiotherapy. And you're going to see this in this region again and again. We've gotten those in the reverse order. I cannot hammer this point enough. Secondary involvement of the pineal region or the brain by germ cell tumors are just still treated with curative intent. Primary CNS germ cell tumors are rare, and therefore they're frequently mismanaged because of their rarity. After proper surgery, the approach now is to give them adjuvant chemotherapy in an attempt to try to minimize the radiation field they're going to get after that.
Thank you. That was Dr. Ala Addashi, hematologist, oncologist. Glad to have you, Ala.
Glad to be here. And that was not pre-staged my entrance with the lymphoma word, by the way.
I think it was. I think you planned it well ahead of time. So we have seen a kind of wide pathology here and differential diagnosis. And we said that they come with the raised intracranial pressure. Why? Because of the hydrocephalus. And they have eye signs. So the majority you'll find headache, papilledema, vomiting, the three triad of raised intracranial pressure, in addition to eye signs. Of course, you can have cerebellar signs, pyramidal signs, but these are the most common. It's called Pineal syndrome. Obviously, the name is French. Henry Pineal, he discovered this syndrome, and he called it Pineal by his name, or dorsal midbrain syndrome, or pretectal syndrome. It's the same thing. It's affecting the eyes, the conjugate eye movements. Briefly, if you want to examine my eyes as a patient, I should close my right eye and should examine the movement of my left eye alone. Then I close my left eye, you examine my right eye alone, and then you examine both eyes to examine the so-called conjugate eye movements. Conjugate to the right, conjugate to the left, upward conjugate or downward conjugate. These are mediated by the medial longitudinal fasciculus and the midbrain and in the pons. So, conjugate upward policy, the patient cannot look upwards. And he has nystagmus. The light reflex is poor. Accommodation is poor. And they have the sunset appearance. This is the sunset appearance we see in hydrocephalus. Hydrocephalus presses on the brainstem and causes the eyes to go down, like the sun going down, sunset appearance. Look at this sunset. And the pupils are mid-dilated usually. So, causes of Pineal syndrome is midbrain compression. Why? Pineal gland tumors or any midbrain lesions like tumors, vascular, or even multiple sclerosis. Why? Because you are pressing in here. And here's the third nerve nucleus, this is the third nerve. So you are pressing on the conjugate eye movements. This is medial longitudinal fasciculus here. So you are affecting this, medial longitudinal fasciculus. This is the fourth nerve coming from the back of the brainstem. Third nerve goes this way, fourth nerve comes from the back. Let's see a video of what is Pineal syndrome. Look at the eyes. Nystagmus. She's asked to look up. She can't. The eyes don't go up. So, policy of upward conjugate movement. شوف تاني. Nystagmus. Loss of upward gaze. Pineal syndrome. And this is a silly question that we ask residents, and they don't know. Here is the nystagmus, looking right and left, severe nystagmus. And Dr. Ammar Al-Baidin gave a lecture about 2 weeks ago of nystagmus. Beautiful lecture. He cannot look up. Eyes don't go up. How many of our residents examine the eyes of their patients? I challenge that. Okay, let's go. So what is the treatment of these pineal tumors? In the 60s and 70s, the tradition was put a shunt, sent for radiotherapy. Believe you me, this is what is practiced in Jordan nowadays. This is what is practiced in the Arab world. This is what is practiced in the Third War. It's a crime against humanity. Shunt is a disease. Putting a shunt is a disease. We should teach residents not to put a shunt unless it is of paramount importance. Now, of course, you do surgery. What are the approaches? Depends on the size, small or giant. Depends on the location. Did the tumor push the vein of Galen up, or did it push it down, or did it go through? So different approaches. And don't you believe that you can do all this with one approach? You will be the prisoner of that approach, and then you will do everything with that approach, and they will kill patients. So, different approaches, above the tent, below the tent, and the idea here is to protect those veins. Damage of those veins would damage the patient or would kill him. So, different approaches. What is the position of the patient? I love sitting position. And you can put him in another position. Dr. Abaisha, you are here. Can you tell us what are the dangers of sitting position? Dr. Abaisha is the anesthetist in Farah Hospital. We need the microphone.
Good morning, everyone. صراحة, sitting position is one of the most challenging positions during anesthesia. As you can see in the picture, as the name tells, the patient will be in completely sitting position. Now, since the skull is above the heart and the patient is, the level is above the heart, one of the scariest things during this operation is the air embolism. That's why preparation for this position is of utmost importance. That's why central line is of utmost importance to us, because if air gets into the sinuses, the patient would suffer air embolism, and this would cause total hemodynamic collapse in some cases. Now, the other major challenge for us is the edema that can be caused if the neck is flexed during surgery for a prolonged period of time. Especially the patients would suffer after the operation. Some of the patients, if the position is not completely well taken care of, they would have tongue edema, and this would in some cases cause total airway obstruction. The other thing is that it will affect the surgical field, because if the veins are compressed, this would cause brain edema, and this would affect actually the recovery from surgery afterwards.
I'm glad to say that we are one of the experts in the world in the sitting position. We have done hundreds, if not thousands, of these cases. Anesthetists and doctors are afraid of the sitting position. It is so good for the surgery, it's so good for the patient. It's tiring for me, but it's good for the patient. It achieves the best results. And I always say, there is always air embolism in sitting position. There is not a single case without air embolism. But the beauty of it, that the anesthetist is ready, he can suck the blood, he will see PCO2 dropping, he will know what is happening, and he will stop it immediately. So this is the sitting position. We open the bone. You may open it above or below in preparation that you may need to go over the tent or below the tent. And this is the left cerebellar hemisphere, right cerebellar hemisphere. This is the straight sinus, the severe sagittal sinus. You go above the cerebellum, underneath the tent, so-called supracerebellar infratentorial. And then you find your own way right in. You will find these bridging veins, preserve them. You can sacrifice one on each side, but not more. You go in, and you face this, a very thick arachnoid that obscures vision. You have to have the courage to cut it, knowing you have millions of dynamite bombs here, which are the veins. It looks like a shark, yes? Mouth of a shark waiting to eat your hand. It is. One of the most frightening moments are this. When I reach to this point, why should I open? And then things, this is vein of Galen, this is precentral vein, this is vein of Rosenthal, so this is the tumor. So you can reach it, because you know the anatomy.
Shark is merciful in
Oh
comparison.
yes, it is. It is indeed. This is one of the cases of lipoma of the pineal region as we are going. It's really frightening. So you can go below the tent, you can go above the tent. No, son. So you can go above the tent, you can move the occipital lobe, you can cut the tent, and then you come up to this area from the side. Again, it is a frightening experience. Mind you, if of all the professions, the shortest lifespan is in the profession of medicine. And if you take medicine in general and look at the shortest lifespan is in surgeons. And if you take the surgeons, what is the shortest lifespan? It is in the neurosurgeons. It is really nerve-wracking, life-shortening experiences.
When you do it properly, as opposed to just...
Yes, of course, if you just want to take a biopsy. So this is the left side, this is the tent, this is opening of the tent, finding the tumor. This is the vein of Rosenthal. So you can go above and below, combined. As I said, through germinoma, you don't need surgery. Radiochemotherapy would do, and it has the best survival. Pineal parenchymal are bad, surgery and radiotherapy, plus minus chemotherapy, and it has the worst survival. And of course we have, in addition to surgery, the endoscopy. I keep repeating, endoscopy is the future of medicine and surgery. So I advise my young residents, if they can go from now, to have the endoscopy training, because it is a long process. The learning curve is very hard and long. And what do we face in these cases? Hydrocephalus. All these cases, 90–100% of cases, hydrocephalus. What is the treatment? Shunt. And what's the excuse? Excuse is, oh, the patient was in emergency. He had fixed dilated pupil and he stopped the breathing. So we had to do a shunt. You are a liar. You can do something better, if you like, quicker, which is the external drain. But you don't do external drain because you have to continue. You have to follow that with surgery. And you don't know the surgery. So what you do is the 60s and 70s, put a shunt and send for radiotherapy. And the other crime is the oncologist who accept these cases and give radiotherapy, empirically. You can put external drain. Emergency, external drain is very easy. Boop, choop, takes 5 minutes. Shunt takes, in the best of hands, takes an hour. So if you want something quick to save the patient life, you liar, you put external drain. And you continue. Other thing that you can do, so Saad Hamdan, ventriculostomy, it's an easy thing. With the endoscope, you can go into the third ventricle, open the floor. The shunt is left for the last cases. And one thing very important, shunt makes surgery very difficult. Why? Because it will collapse the ventricles. And then I don't have the space to operate. Look at this. Criminology at its best. The tumor is there, and they put the shunt. Stupid and criminal. And look at this shunt. This man should be taken to court. This is crime. He is passing through the motor area. Nobody has taught him this is the wrong place. You should be here, going to the occipital horn. Occipital horn will take you to the triangle, which is the largest area of ventricle. So we teach residents to do shunt, but even we don't teach them how to do it. Just put the shunt, get CSF out. You will get CSF out, but the patient will be hemiplegic. Look at this. This is a practicing neurosurgeon in Jordan, head of a department. Look at this. Vascular tumors, you can hit veins, you can kill the patient. Look at this. This is nothing. I mean, I can't describe it. Whoever has done this has no idea, and his boss has no idea. Some people will take a biopsy. Rarely you need so. As I said, germinoma, maybe, if you are in doubt, you do biopsy. So this is germinoma after radiation chemotherapy. What about radiotherapy? Is useful? Yes, it is useful. Almost all of the pineal tumors, they need radiotherapy and chemotherapy. One quarter doesn't need. Epidermoid, arachnoid cyst, meningiomas, etc. This is the dose. You give it to the whole brain, you give a booster dose to the tumor bed, and you treat the neuroaxis, the spine, because there is at times some metastasis. And this is the radiotherapy and the effect of radiotherapy. Chemotherapy, mostly it is cisplatinum.
Cisplatin based.
Of course, cisplatinum.
And we try to give it before the radiotherapy in an attempt to avoid the whole brain radiotherapy and germ cell tumors because of the long-term toxicity.
And it is useful.
And absolutely.
What about survival? Let's sum it up. Pure germinoma, very good survival, as you said. It's one of the best tumors if it is a pure germinoma. 5 years, 95% of your patients are alive. At 10 years, 88 are alive. But look at this here. At 10 years, nobody is alive. Half of them, 1/4 of them is alive after 5 years. So these are malignant tumors. And this is a benign tumor. My series. Since I came back from England till 2017, I always keep two years ahead of time. I had 61 patients. I only had 48 to follow up. The others lost. The male to female preponderance was 3-1. Unfortunate for us males. What about radiology of these cases of mine? These are my cases. MRI would show you this in T1 with contrast, in the flare, and various sequences, usually contrast enhancing. So without contrast, with contrast, T2, flare, and so on. And with the diffusion, ADC, the plan, they have some restriction. Sometimes you'll find hemorrhage and calcification, because pineal glands usually calcify. So sometimes the tumor you will find calcification. These are the MRIs of my patients. None of these pictures are from a book or from internet. If somebody of you would challenge me, I will get him the file of this patient. These are my patients. And for anybody to stand on a podium and speak about the subject, tell us about your experience, not about the experience of the others, the books, the internet. I'll go through that quickly, just to show the different sizes and shapes, different pathologies. You don't need to memorize them, just for the sake of honesty, I'm showing this. CT, it will show you calcification, because pineal usually calcify. So is this calcification within a tumor, or is this the usual normal calcification of the pineal gland? This is a major question. This is to show you that normal pineal gland calcify. Ask any resident, and all residents know this, calcification on skull X-ray, pineal and coronal plexus. Everybody knows this. But sometimes you find this, tumor and calcification. This is important. The MRI, you can see the vessels. Look at here, vein of Galen and intenocerebral vein. So you can actually see vessels on the MRI. And the MRI itself would tell you what is, for example, it shows me here that there's occipital sinus. If I'm not aware there is an occipital sinus, I will open the dura, patient will die on table, because you will have massive air embolism. And look at here, again, what I call this, a radiology technician who is a freelancer, who's not supervised, and he puts this. We are looking at pathology here. Why should you put this line? You are taking information off. And also to show arteries and veins on top of each other is another fault. A technician who is not supervised, he would do this. Pineal cyst. I promised you to come back to the pineal cyst. Is this a cyst or pineocytoma? Here is the fibrosis or capsule, and this is the gland. Capsule and the gland, the cyst. So you should know what is the normal MRI appearance of the pineal. And what is the size of the normal? This is the size of normal pineal, 10 to 14 millimeter. So pineal cyst, various examples. Pineal cyst. This is from Osborne, Anne Osborne, famous radiologist. Pineal cyst. Sometimes you have hemorrhage into the pineal, apoplexy, like pituitary apoplexy. Pineal cystic changes. This is a paper in the Neuroradiology 2016, a recent paper of 232 patients. 56 had cyst. 56 of the patients had cyst. It could be a single cyst, it could be multiple cysts, it could be multiple cysts with increase in the size of the gland. You should know this if you are reporting on an MRI. How many of our radiologists know this, I wonder? And they follow these cysts. They found that some of the cysts remain stable, but some of them has increased. This has decreased, but this is the importance, that even if it is a cyst and it is benign, it can increase in size and become symptomatic and needs treatment. Is this a pineocytoma or a pineal cyst? We look at the calcification. Where is the calcification? Is it in the center of the gland or pushed aside? Again, this is from Anne Osborne book, because both comes in young children. And pineocytoma is part of a triad with a retinoblastoma. So you look at this. A cyst with the rim of calcification This is pineocytoma. What about some illustrative cases of mine? This is epidermoid tumor that we removed. This is the post-operative, and this is the histology. So these are real cases. Another case of epidermoid, before surgery and after surgery and the patient. Further epidermoid follow-up. Another massive giant epidermoid before and after surgery. And this is what you see, as I said, when you remove the epidermoid, you see the pineal gland. In a way, you can never see it except in epidermoid. Arachnoid cyst in this lovely lady from Jerusalem, 73-year-old, with this hydrocephalus, jump into a shunt. No. If you remove the cyst, there is no need. We did, without a shunt, and followed thereafter. Another, this is the one I told you about, the astrocytoma. And this is the post-operative, and this is a follow-up. And this is a young girl also with astrocytoma in the back of the midbrain. And this is post-op, and this is the histology. This is long follow-up. No shunt. I don't want you to put a shunt in my baby, boy or girl. This is a disaster for me and for the girl and for the boy. Don't do it to others if you don't like it yourself. Stop doing shunts. The whole world has stopped doing shunts. Why are we keep doing it? Why? Because we have mediocre neurosurgeons who cannot deal with the tumor, so they put a shunt and then send for radiotherapy. End of the story. Lipoma, causing actual... The patient is tilted because he has fourth nerve palsy. If you have fourth nerve palsy, you have double vision. So the patients will do this to compensate for the double vision. So this is lipoma, and I showed you the operative finding. This is the fourth nerve in the back of the midbrain, and that's him. And you can see that he can look very well without double vision. He's from Bahrain, and he works as a guide for the airplanes. Meningioma in this man from Jordan with this tumor. That was actually recurrent after previous meningioma a few years ago. And post-operative on himself, and this is the histology. So we deal with different pathologies. Now the presentation of today will be very quick. This is again, I don't know what about the Bahrainis. They have lots of these pineal tumors. 37-year-old from Bahrain. The year is 2010. Headache, decreased visual acuity, double vision, increased intracranial pressure with double vision. Amnesia, urinary incontinence. Why? Because of the hydrocephalus. Upper limb weakness, pyramidal signs. Vital signs were normal. Neuroexamination, as we said, was within normal. Cranial nerves, they had partial third and fourth, both. And he was incontinent of urine and feces. Ibrahim said that, are you around? I'll get you when we reach to that point. But he had major eye findings. Power was decreased slightly in his right upper limb. Planters were down, just to say normal, ECG normal. CBC, liver functions, except GGT and DLT was slightly elevated. And this you can pass easily as normal. And we have done the chronic gonadotrophin and the AMV, they were negative. They were not elevated, so we are not dealing with a germinoma. These are the images. There's a large tumor here. We describe the radiology of these cases. Again, this is a radiology technician who is not under supervision. Why are you putting this line? Actually, I've seen them. They take a pen and on the screen they put this line. Because when he received the machine, he was taught to do so. Why? He doesn't know. He just put it. This is a posterior fossa pathology. I need to see what's going on here. So his boss is not looking after him. So he had hydrocephalus. Did we jump into shunt? No. We did a few consultations. We always do psychiatry because he has amnesia and mental changes. At that time, we asked Dr. Arabi Al-Borno, sometimes we asked Dr. Wali Sarhan, Dr. Samawi, to do Karnofsky Performance Scale. Is Karnofsky Performance Scale important in oncology?
Absolutely.
What's the importance?
Prognostically, it's probably the single most important prognostic piece of info, and it's the easiest one to get.
Absolutely. And nobody does that. We do it. We've been doing it for 15 years now. Ibrahim, the ophthalmology of this patient who has third, fourth.
Good morning. I'd like to elaborate on one point I mentioned earlier. Don't use your cell phone or tablet before sleep, because this will stimulate your pineal gland to secrete melatonin, and this will cause sleep disturbance or keep you awake. So this is a recent issue that was noticed. Instead, you can download the application for that. It is called blue light filter, because the blue light is a daylight and it will stimulate your pineal gland. Actually, in pineal locus tumors, we need, sometimes I ask Dr. Ibrahim, if you have a pineal gland tumor, please tell me in advance, because I want to look for signs, because we don't usually do this in our daily practice. We don't look for this nystagmus. If we have an up-gaze palsy, sometimes it's normal in elderly, so we don't look for all these signs. But whenever he tells me that I have a pineal gland tumor, or the MRI tells me that, I look for signs, because sometimes the nystagmus, it's not a nystagmus, it's not a real nystagmus, it's a nystagmoid movement. Nystagmus is rhythmic, it is not rhythmic, and we can induce it if it is not apparent, by telling the patient to look from down to up. The eyes will converge in a rhythmic way, okay, and the eyes will retract. This is what we call abduction, convergence, retraction, nystagmus. Also, sometimes the patient will have a Collier sign, lid retraction. Another important sign sometimes we don't look for is near light dissociation. The patient has a sluggish reaction to light, but his reaction to near is preserved. So these are signs that are found in Pineal syndrome that we see in pineal locus tumors. In this case, we have impaired lateral and upward gaze. Upward gaze because it's part of the Pineal syndrome, but the abduction, which is the lateral gaze, it has two causes. Either it is from the increased intracranial pressure, or it's what we call thalamic esotropia or pseudo-esotropia. Does he have papilledema? So this is his visual field. I think he had papilledema, right?
Yes.
Okay, thank you.
Thank you. Also, we asked our chest physician, Dr. Ad Suleiman, to do his spirometry. He found some decreased values. Dr. Ziad Awad, as a nephrotic surgeon, kidney surgeon, because he had urinary incontinence, what can we do? Whether it is related to urinary infection, it was related to the hydrocephalus. Set of examination was done, urine tract ultrasound, and at that time Dr. Jamal Sharif was the anesthetist. He declared the patient as American Society Association grade 3. We got the consent. As we said, consent is different from what is written in hospitals. Every patient has his own consent with his own information about his own condition. You just cannot write a consent for everybody. For the lady who's going to deliver, for the girl there who's having hysterectomy, for the boy who's having tonsillectomy, for a patient with a brain tumor. They can't be the same consent form. This is ridiculous, and it should be stopped. If I'm traveling, I tell the patient, the most ugly thing that the patient has complications, and then you have to leave, and the patient would say, oh, he did the surgery and he left for his holiday. So you should tell the patient, after surgery, I am leaving, so-and-so is going to take care of you. Surgery, شوف الفيديو بسرعة. So sitting position, this is the right side, this is the left side, this is midline. These are the veins that you will face. It's called vermian drainage veins or hemisphere drainage veins. You may choose to go on one side or the other. You may choose to go on the middle, depending on what is the arrangement of these veins. And there is no patient which is similar to the other patient. It's totally, completely different set of arrangement. So you have to look, you have to study the MRV, the venogram, and decide which window I'm going to do. I'm going this way, or going this way, or going from the midline. If you damage these, you will get cerebellar infarct and death. Simple. Venous system is ignored. So we're looking for a window to go through. It seems that the right-sided window is okay, but we have two windows here. Midline is impossible because of the arrangement of these veins, so I decide to go above the cerebellum on the right side. This is the straight sinus. This is the confluence of sinus, superior sagittal sinus coming here, right straight sinus, left straight sinus. So these are the midline.
How much pressure do you apply on the cerebellum?
Very little, just to see. Actually, if you can see the retractor, it is curved like this. It's just to hold it. If you put pressure, you will get cerebellar swelling and prolapse and death on table.
Subjective, not weighed or measured?
No.
Not much, okay.
So this is the arachnoid I'm telling you about. Here is the moment of the truth. Here is the nerve-wracking. Here is the life-shortening moment. You don't know what is lying there behind these things, so where to open? And the arachnoid there is very thick. You have to cut it with a knife or with a scissor. It will not go. Very tough, standing in front of you. You know the tuft of veins that are there. So slowly, gently, you find a window and you scissor. It must be used a scissor, a sharp scissor. Remove the arachnoid, preserve the veins. This is the placentral vein. This is vein of Galen here. This is vein of Rosenthal. So I found a window. By that time, your life is 1 year shortened. So this is the tumor. You dissect it from the surrounding. Vein of Galen is here. Vein of Rosenthal is here. The internal occipital vein is here. So this is the tumor. And we start taking it out. And once you take it out, you will go into the cavity of the third ventricle. So again, anatomical knowledge. So you can see now the cavity of the third, but still there is lateral extension of the tumor. The white stuff here is the pulvinar of the thalamus. So you can see the cavity. This is the cavity of the third ventricle. But still the tumor has extension this way. Some terminology, this is the roof of the third ventricle. This is the coronary plexus and the roof of the third ventricle. These are two internal cerebral veins coming our way here. Here you are, roof of the third ventricle. Still there is a tumor. We have to remove it completely. Some terminology is used, and this is very bad. They speak about decompression. I've done decompression. It's enough. No, it's not enough. You are going for a kill. You are going for a cure. So you have to remove every bit of the tumor. still there is a tumor here. So I open another window here. And I bring the tumor to the major window. This is the vein of the tumor. I have to differentiate this from the veins there. "10 hours, 12 hours, I don't care. There is a job that has to be completed." So here we are. Third ventricle is open. No shunt, no misery of a shunt. This is vein of Galen, vein of Rosenthal, central vein, all being preserved, and we do the hemostasis. Okay. So it's a difficult surgery and should not be done by the beginners or the novices.
Sorry, is the time 10 hours usually?
Sorry?
Is it 10 hours usually?
Oh yes,
Yes?
yeah,
In sitting position?
in sitting position.
And that doesn't cause edema? as you
Absolutely.
said?
If you put the neck in a proper position, there's no problem. Should not be completely flexed. You keep 2-3 fingers so that you will not close the jugulars. Patient is sitting so that you will preserve his sciatic nerve. Cushions and knees are flexed and foot support, and we take care of all that. As we are operating, we take CSF because CSF analysis is important. We're looking if there is any cells that we can find, no malignancies, and we come to histopathology.
Assalamu alaikum. I'm Hussam, a Farsa pathologist. Will show this very interesting and rare case. This tumor shows sheath of cells. There is a lot of hypochromasia and mitotic figures in these areas. Tumor cells, they look not benign looking. There was some areas that look pseudobabily fragmented cells here. You can see this is most of the tumor look like this sheath of hyperchromatic cells with some mitotic figures, and they tend to arrange about forming pseudo rosettes or rosettes around some of the blood vessels. We'll show you more, and you can see how the cells they look ugly actually, and hyperchromasia, polymorphism in sheath, and there were mitotic figures frequent. Sometimes there is intranuclear inclusions. Again, you can see hyperchromatic cells in sheath, very cellular tumor, and they tend to arrange around some blood vessels, forming pseudo-papillae. Again, it's like pseudo-papillae, but look at the cells, how they look ugly cells. With the mitotic figures were high, about 8 per 10 high power field. We did immune staining for this. This is nestin stain, usually embryonic cells, and you can or primitive cells. You can see the sun ray appearance around blood vessels, مثل الشمس اللي طالعة, and this is typical for nestin staining in these tumors. And this is neuron specific enolase, and you can see most of the tumor cells they are stained. And this is typical of tumor. And synaptophysin, the brown staining is the positive staining, is staining in these areas in this tumor. Ki67 was high in this tumor. It's about 10%, indicating that the tumor is proliferating. Cytokeratin 18 was negative, and this was important because this tumor is parenchymal tumor of intermediate differentiation, and the other differential, because of the formation of pseudopapillae, the papillary tumor of the parenchyma or pineal gland, and this was actually the diagnosis that came from Bahrain. But they forget that the cyanotophysin is negative in papillary tumors, and cytokeratin 18 should be positive. This has the reverse. So this confirms that this is pineal gland tumor of intermediate differentiation, because the high mitotic activity and the high Ki67 we grade it as grade 3. So this is actually bad tumor. So we call it pineal parenchymal tumor of intermediate differentiation grade 3. And also I mentioned that we should follow this patient with melatonin follow-up. Actually melatonin usually is not done in Jordan. I tried to do it one time. I brought the kit, but nobody asked for it, so I don't think that it's done in Jordan,
That's right.
melatonin.
Thank you. So this is a highly malignant tumor, but we have done good for the patient. We have removed most of the tumor. It is infiltrative, so you cannot claim total radical excision, but it is radical excision nevertheless. Post-operative course, he was well on table. He must be well on table. We don't send patients to ICU on ventilators, as some people do, with the claim that we want to rest the patient. It's long surgery, so let him rest. It has no meaning. There's nothing in medicine like this. It's a creation of their minds. Patient developed atrial fibrillation for no reason, but because we are on the brainstem, we have to be careful. And we asked Dr. Munir Al-Zuqa to see him. So he was treated by just medicine, and brain MRI was done the following day. No shunts, no extended range, nothing. So again, we followed his atrial fibrillation, which started to, and we did post-operative, a Karnofsky performance scale, before and after. And he scored 90, which is good.
60 was.
A patient was doing well, so he was discharged. Again, discharge summary. The single miserable paper that we write discharge summary on. Admitted on the 11th, discharged on the 13th, craniotomy was done for the tumor. يراجع العيادة. يراجع العيادة. What time, for whom, nobody knows. So it has to be complete like this. And discharge summary, start on admission. Residents should put the history as the patient comes in. They put the investigation as they are done. They put the operative note as they are made, and so on. So by the day he is discharged, the discharge summary is ready. As the patient, that's what happened in my clinic. And we did the neuro axis to see if there is any seedling, no seedling. So we sent him, we advised radiotherapy, would you like to do it here or in Bahrain? He chose to have it in Bahrain, and during his radiotherapy he developed hydrocephalus, and the VP shunt was inserted. 6 months later, this is his follow-up, nothing, complete cure. No misery of anything. He keeps his hair always low cut. 9 months later, he's well. 2.5 years later, he's well. 3 years. Look at this. Nothing. Nothing. And 3.5 years later, nothing. And 5 years later, nothing.
I have a question, Dr. Sami. Would patients, because of edema during radiotherapy, can they, in this region, can they develop adipose?
Yes, but usually it's very rare. Usually
Exactly.
it's very
So,
Maybe they have seen some dilated because the point I want to mention is this. Once the ventricles are dilated and you remove the obstruction, the ventricles do not go down to the normal size.
absolutely.
They're still dilated. So some people may translate this as hydrocephalus that needs to be treated. I think this is the...
So, exactly. So, my point exactly, the edema during radiotherapy should really not cause true
Sometimes it does.
It's actually rare, but in what? So your take on this is probably it was misreading
Yes.
or misinterpretation
Absolutely,
of the
absolutely. Yeah. Any questions? We finished. Before you go, next week we'll have a very interesting topic, which is orbital tumors. Orbital tumors are missed, and the people are doing it are not really doing a good job. So we'll discuss
Last
the
follow-up was in
recently. This is recent.
and it's still doing
Yeah.
well.
Yes. Absolutely.
Very recent.
So we finished the topic. Please, any questions?
Yeah, just one please. We said pineal gland cysts don't need operations, but I'm not quite sure other than how they look on radiology and negative tumor markers. How would you decide that this is a cyst?
Yes. How do we decide this is a cyst?
Other than radiology and
yes.
negative tumor markers. Is
Sure.
this all what we need?
The words of wisdom are this. If you suspect a cyst versus pineocytoma, wait and repeat the MRI.
And
3 months.
Okay.
I keep repeating them 3 months.
But you said some of them, like up to 40% might increase in size.
Sure, some of them they increase, some of them they don't. So by following them up, I would tell whether they need, even pineal cyst, if they have increase and cause obstruction, they need treatment.
Yeah.
But this is not my aim. My aim is to differentiate between a pineal cyst versus a tumor. And by doing the alpha-fetoprotein, SCG, and melatonin, I can sometimes differentiate. If I don't, I operate.
Okay. And if you got a patient in emergency, like loss of consciousness,
Unconscious fixed dilate pupil, external drain.
external drain, and how, what's the time interval between the external drain and your
My surgery, 1, 2 days, 3 days, until the patient
so we
is.
still have time to like do more blood tests and
Of course.
MRIs and
Because this is a good time to transfer patient from Australia to here in an aeroplane with external drain.
With the external drain, does he need to stay in hospital?
No, not at all. No. If you give them the proper instructions, the best thing for external drain is to keep it closed and open it only in emergency. So a patient can fly with the external drain closed, and with the nurse or somebody with him that to open the external drain if there is a need. So external drain is easy, quick, it solves the problem. At the same time, it gives you time to plan. And what people say is that, oh, it's the same thing, you will collapse the ventricles, so surgery would be difficult. What we do is to close the external drain 12 hours before ventricles get dilated, we operate. So putting a shunt is an excuse for the ineffectiveness and insufficiency of these mediocre surgeons. The problem is that they teach this to the newcomers, to the new generation, and we are getting a generation after generation of unexperienced surgeons with the wrong information.
Thank you.
Please.
I just can't overemphasize what you mentioned, Dr. Ibrahim. When you follow this, when you follow this by burying the evidence with radiotherapy without even having had a tissue diagnosis, and we've discussed the how vast the differential diagnosis is. And if you just have had a shunt and you've buried the diagnosis with radiotherapy, and then the patient will progress, and then, well, he has cancer, of course he's going to progress, etc. Some of these patients would have been cured without actually resorting to full excision. Some of them would have been cured after surgery with radiotherapy. Some of them would not have needed anything after surgery. The spectrum of management after that is huge, and you just bury that by the evidence. And unfortunately, we see this on a daily basis.
Okay. Thank you, Dr. Ibrahim. My question is about the pineal cyst. Sometimes it's very difficult to differentiate between pineal cyst and pineocytoma.
Sure.
Anne Osborne mentioned that the pineal cyst could be a multicystic, could be a thick wall, also could be a nodule within the cyst and gives the target sign, which is very difficult sometimes to differentiate.
Sure.
My question is, if the pineal cyst is more than 1.5 centimeter, can you put external shunt, or you can follow your patient?
No, if I want to operate, I would operate.
Even it's pineal cyst?
Even, yes. If it is symptomatic, I would operate. But first, I would have to be sure that this is a pineal cyst or a pineocytoma. And as I said, in Anne Osborne, there is some differentiation. She says that if the calcification of the normal gland is pushed to the side, this is most likely pineocytoma. If it is buried inside the gland, this is most likely a cyst, and so on. So sometimes you can, sometimes you can't.
The calcification?
It's calcification itself within the tumor. Is it in the midline? Or
If it's in the midline, it's parenchymal tumor.
Yes, as I said, there is
It's in the peripheral. If it's in the peripheral, it's a parenchymal tumor. If it's in the center, it's germinoma.
Germinoma,
Yes.
true. Yes, true. So by looking at the calcification, you can differentiate. Any questions, any comments? If not, thank you, and we'll see you next Wednesday with orbital tumors.
كفل الأوربيتال تيومرز. اجتك مريضة من الكرك؟ كده. بتحطوا بيس لاين.
It is not effective because if it improves 60 to 90, then this is good. Okay, if it improves, then this is good. You know, it's not